Chevron Akin Osteotomy. Diagnosis: 54-year-old woman with symptomatic hallux valgus of the left foot, intermetatarsal angle 14 degrees, hallux valgus angle 26 degrees, and a proximal to distal phalangeal articular angle of 12 degrees. In this case, we will perform a chevron osteotomy on the MT1 and an Akin osteotomy on the proximal phalanx and fix the osteotomies with 2 cannulated compression screws. Anatomical landmarks and approach. Start with a strict medial approach for a good soft tissue coverage and a safety margin of the dorsal and medial nerve and vascular structures. Full thickness preparation of the skin is recommended to avoid wound healing complications. Optionally, in the case of a pathologic plantar position, the abductor hallucis tendon is detached from the capsule through a tangential cut and secured with a stitch. Later, the tendon can be anatomically reattached. Joint preparation. A Y-shaped cut of the capsule is performed to allow for a better adjustment of the excess capsule at the end. Joint plica or capsule duplications should be removed. Lateral release. In cases with contracted lateral soft tissue, a release of the lateral capsule and lateral ligament is done with a maglanory elevator. Sufficient varus should be checked. If necessary, a transarticular release of the lateral metatarsosesamoidal ligament is recommended. Chevron osteotomy. A prominent pseudoexostosis is removed. Care is taken not to damage the sesamoid glide area. A K-wire is inserted in transition from upper to middle third of the metatarsal height, just dorsal to the center of the metatarsal head. By angulation of the K-wire, lateralization, lengthening and dorsalization, as well as shortening and planarization can be achieved. The plantar cut should aim behind the capsule insertion to the metatarsal head, not to damage the arterial blood flow. The dorsal cut should be less than 90 degrees to the plantar cut for intrinsic stability of the osteotomy. The dorsal cut is performed first, followed by the plantar cut. By removing a wedge of the metatarsal, a DMMA correction is possible. Mobilization of the head is carefully performed with a chisel. If necessary, remaining periosteal connections lateral can be cut with a chisel or knife transosteotomy. The head is shifted laterally to the desired position. By using a Hohmann retractor or a clamp, the metatarsal can be moved medially to allow for a better lateralization of the head. Screw fixation. The metatarsal head is fixed in the desired position. A K-wire is aimed in the center of the metatarsal head. The achieved position can be checked by X-ray. Countersinking is recommended not to crack the dorsal corticalis during screw insertion. Screw length can be measured. In general, a length of between 18 to 22 millimeters is needed. Drilling is not necessary in most cases. The screw is slid over the K-wire and inserted with a screwdriver. Compression begins as soon as the head threads into the upper cortex. The overhanging bone is removed with a saw. Akin Osteotomy. An Akin osteotomy is recommended in most patients. The proximal phalanx is prepared. The soft tissues are protected by Hohmann retractors. Special care is taken for the flexor hallucis longus tendon, which runs in a bone channel with a retinaculum. The incomplete osteotomy is done in the proximal third of the phalanx, perpendicular to the corticalis, aiming proximal. A 2 mm cut is in most cases sufficient. The amount of correction is judged by intraoperative and radiological findings. The wedge is removed and the osteotomy fixed, in this case with a compression screw. Countersink is recommended to not crack the corticalis. The screw is slid over the K-wire and inserted by a screwdriver. Compression begins as soon as the head threads into the upper cortex. Closure. The Y-shaped, incised capsule is sutured proximal, and the two flaps are sutured back, which allows for tightening of the excessive capsule. Care must be taken not to over-tighten the capsule, as this increases joint pressure. Skin closure is done with single bottom stitches. Postoperative care. Full weight bearing with a post-op shoe for 6 weeks. Physiotherapy with MPT-1 mobilization is recommended after wound healing. The post-operative X-ray shows a good correction of the deformity and secure bony healing.